Welcome to this month's Visual Pearl, brought to us by the Society of Pediatric Pain Medicine. We are excited to talk about superficial cervical plexus blocks and its techniques. Thank you for joining, and let's jump right in. Our goals for today's talk are to discuss the indications, contraindications, techniques, and high-yield notes for the superficial cervical plexus block. Common indications for surgical and postoperative analgesia include carotid endarterectomies, cervical lymph node dissections, and superficial neck procedures. In the emergency room, this block can be used to provide analgesia during earlobe repairs, central line placements, or even submandibular repairs. Situations where we would not choose the superficial cervical plexus block, or at least choose it carefully, are previous neck surgeries that may alter the anatomy of the plexus or active infections in the area. Another important point to consider is that the superficial cervical plexus block can have potential phrenic nerve involvement on the ipsilateral side, so we should be mindful when considering patients with pulmonary comorbidities. Once we have found the perfect patient, positioning is fairly simple and familiar to central line placement in the internal jugular veins. Our major landmarks that we should be able to identify are the posterior border of the sternocleidomastoid, the mastoid process, and the clavicle. We can achieve this by placing the patient in the supine position and have their head turned away from the block site. The landmark technique can be performed safely as long as we are mindful of a few points. First, after finding the posterior border of the sternocleidomastoid, we locate the midpoint of the muscle between the mastoid process and the clavicle. At this insertion point, the goal is to deposit local anesthetic in a fanning fashion no deeper than 1 to 2 centimeters from the skin. The local deposit should be about the size of a quarter or between 2 to 3 centimeters in diameter. This should adequately cover the branches of the plexus as it emerges from behind the sternocleidomastoid at this point. For the ultrasound technique, we place the transducer probe in the transverse position at the midpoint of the sternocleidomastoid as described in the landmark technique. A hyperechoic nerve bundle should be apparent at the posterior border of the muscle belly. With in-plane technique, we should aim to deposit local anesthetic above and below this muscle belly to supply adequate coverage to the plexus. Again, we should be aware of potential ipsilateral phrenic nerve involvement with this block, and using a volume of local anesthetic between 2 to 7 milliliters should reduce the risk of pulmonary complications. Thanks for joining us today, and we'll see you next time.